We now dive into a topic that is constantly evolving, keeping us all on our toes. As chemotherapy and immunotherapy advance, so must our approach to preoperative care. For the next session, we have Dr. Josh Thomas George, Associate Professor from the Department of Medical Oncology, to take us through the preoperative guidelines to chemotherapy and immunotherapy. Guiding the discussion and enriching it further are our moderators, Dr. Kirbakaran, Professor, Department of Cardiac Anaesthesia, CME Vellore, Dr. Smitamal, Professor, Department of Anaesthesia, and Dr. Meghna Jeevanmal, Professor, Department of Anaesthesia. I would request all of you to kindly come up on the stage.
Hello, everyone. So, in this topic today, I would just like to say in the beginning that today's oncology patient is no more just a post-chemo patient. With the new adjuvant chemotherapy and also the immunotherapy, the drug-directed toxicities have made our anesthetic planning also slightly different than what we really practice. Today we would like to introduce Dr. Josh Thomas George. He's not a new face to anesthesia, and some of us might know him who have been here, that he had a short period with us. And we would like to invite you, Dr. Josh, to speak on chemotherapy and immunotherapy. Over to you.
Thank you, ma'am, and good afternoon to the chairpersons and everyone here. So like ma'am said, I'm right now a medical oncologist, but 13 years back I was in anesthesia as a junior doctor, and probably that's the reason why I think Amit chose me to talk about this field, which is possibly, I mean, all of us think it may be completely unrelated, and why have such onco-anesthesia guidelines, or why should we change from standard practice when cancer patient comes for surgery or anesthesia. So the changes, like ma'am had mentioned, is that perioperative systemic therapy is the standard now for many cancers. So it's not just you go to a surgeon, you have a resection done, then you come for adjuvant chemotherapy. That paradigm has shifted to most patients getting neoadjuvant, which means before surgery there are advantages of possibly curing micrometastatic disease, possibly shrinking the tumor, and equivalent survival as when you do the adjuvant therapy. In some cases, when we give chemoimmunotherapy in the earlier phase, it's like an in vivo test to see how the tumor responds, and then we can prognosticate and escalate therapy after surgery. So this is a paradigm shift which has happened in the last few decades. The drug classes in oncology have expanded over the last 2-3 decades, so much so that it is difficult for us to keep track of these drugs which come out almost every single, I would say every single week. And these new molecules which are coming out, because we are understanding the biology of cancers better, so if it's difficult for us to keep track, I can imagine with your volume of work and what you have to keep track of, it's extremely difficult to kind of keep track of the toxicities. What does this drug cause? What is this drug? So it's good to have a marriage of two fields and have some guidelines so that both the oncologist as well as the anesthesiologist has an idea of how to guide our patients safely through a perioperative setting. And most of you, I mean, all of you would have been exposed to patients who have had chemotherapy, but more and more patients will be coming to you with having exposure to targeted therapy and possibly the side effects of those drugs. So I just want to start off by saying that, our fields may not be totally different. So we all have our little box of medications. I remember in anesthesia time, morning we used to come and load all the drugs and keep it ready. So I do kind of similar thing in oncology as well. We also have our box of drugs and we also load those drugs to give to our patients. So that is quite similar between the two fields. We also have a cabinet of curiosities in our department. Just like you have an anesthesia machine, we too have a chemotherapy laminar flow hood, which we safeguard, and we use it daily for our patients for mixing chemotherapy. Another similarity which I thought was evident is that sometimes the general public and even our colleagues kind of misunderstand us. So some people think, that anesthesia is just some gas man or woman, but because I've been exposed, I know it is definitely, the field has advanced since the time I've been there, but I know that you take care of, it's a very difficult field, and it's really advanced since the time of Morton, and it's really, it's not just about, giving anesthesia and coming out, it's about anticipating so many risks and taking care of the patient, bringing them through a very traumatic situation for the body in a very safe, and so much so that the patient doesn't even realize. Recently my mother had a surgery, she didn't even realize what happened during the surgery, she was extremely happy. So that's the importance of anesthesia, and also the most important thing, right? So we annoy the same people, our dear surgeons. So both of us, we sometimes tell them you cannot operate. So we also tell them you cannot operate, we'll start chemotherapy. So if there are any surgeons in the audience, please forgive me. So I feel the task has been given to me is to give you an update on what has happened in cancer therapy. So that will be the talk, and as well as trying to give a road or a roadmap for some guidelines. So what has happened is we have entered from the era of chemotherapy, we have entered a targeted therapy era where we understand the biology of the cancer, what is happening inside the cancer on the surface of the cells, and we're targeting those problems which are there in the cancer cell. So we had an era in breast cancer where we found out trastuzumab kind of helps with HER2 positive breast cancer. We have multiple TKIs, tyrosine kinase inhibitors, which has come in. The era of immunotherapy revolution set in the late 2010s, and perioperative therapy, which I mentioned earlier. So this all started off, the first targeted therapy I would say was actually tamoxifen for breast cancer, but we had this person who actually, there is a movie based, if you can watch the movie, it's a very nice poignant movie. So Dr. Slemon actually discovered that this HER2 receptor is there on the surface of breast cancer cells, and if we target that with a drug called trastuzumab, it actually kills those cells much better. So from a HER2 positive breast cancer being the worst type of cancer, it is now probably the best type of breast cancer. So then we went on to targeted therapy. So in lung cancer has been a very major successful field where we have found out what is the inherent biology. So in around 2004, scientists discovered that there are mutations within the lung cancer cell, around 30 to 40% of them have a mutation called EGFR mutation. And then incidentally, this was not developed, this drug was not developed to target that. But then this drug helped patients who are on their deathbed with metastatic lung cancer, just giving them this tablet kind of brought them back to life. So it was so much so that it was called the Lazarus effect. And it was a landmark observation that it really responded. So now we have moved ahead from that first generation tablet to a third generation tyrosine kinase inhibitor, probably fourth generation coming in the next few years, where we kind of improved survival. We have not cured, obviously, metastatic lung cancer, but we have improved survival for patients, and they just have to take a tablet, right? It's not like they have to take chemotherapy and then, it progresses after a few months. On the tablet, the disease is controlled and responds well. Some of them even have complete remission for 2-3 years. So this is the doctor who's actually from Kilpatrick Medical College, who's in the US, who actually led these trials for osimertinib, which is the latest drug. And we have even in the perioperative setting. So this is mostly, first, all drugs in oncology start in the metastatic setting, and even adjuvant setting, right? We have this tablet. So once a patient has operation for lung cancer, if they have the EGFR mutation, we give them this tablet for a couple of years, and the survival dramatically improves, as you can see from this Kaplan-Meier curve. There is another cancer which I'm just telling you about lung cancer because it is a poster child of targeted therapy. In ALK positive lung cancer, which is around 5 to 7% of patients, in stage 4, these patients are, I would say, with current therapies, we've almost cured, we have achieved cure, because they live for median survival with the older generation tyrosine kinase tablets was around 7 years. Now we don't even know how long these patients are going to live. So if you have a patient with ALK positive lung cancer, we give them a tablet called lorlatinib or alectinib, and the disease is controlled and in remission for, I hope, more than 10 years. So this is stage 4 lung cancer, where patients used to die in 9 months. So this is the list of targeted therapy molecules. This is just in lung cancer. These are the mutations which are seen, and these are the targeted therapies which are either available, FDA approved, or being investigated. So this is all possible because we have these NGS technologies and we understand what exactly the mutations are there in cancer. And the cost of NGS has come down significantly since the Human Genome Project, which was around 2 decades back. and this is the improvement in survival. So going on to what is relevant. So this is just an update about what happened in the field of oncology in the last 2 decades. So when you see a patient with cancer, these cancers, right, gastric cancer, triple negative breast cancer, lung cancer, melanoma, HER2 positive breast cancer, bladder cancer, all these patients now don't come upfront for surgery. The standard of care is that they will get either chemotherapy or immunotherapy, then they come for surgery. So that has become the standard across many malignancies. Locally advanced rectal cancer, as you know, from before itself, we had long course chemo-RT or short course chemo-RT. From that, we moved on to something called total neoadjuvant therapy, where all chemotherapy is given before the surgery. Pancreatic cancer, ovarian cancer, even GIST, when it is locally advanced, and GIST is a gastrointestinal stromal tumor, where again we just give them a tablet called imatinib and they respond very well. So even those patients will get the tablets and then they come to us. Osteosarcoma. The standard of care is we give them 6 cycles of chemotherapy, then bring them to surgery. So what is the relevance of all these things for you is that most patients, please do not, this is just a busy slide, but I just want you to concentrate on the initial part. So most patients, breast cancer I'm taking as an example, most patients will have, whether they're hormone positive, HER2 positive or triple negative, many of them will have neoadjuvant therapy. And this neoadjuvant therapy is not just chemotherapy. If it's HER2 positive, they will have probably now dual HER2 blockade. Many of our patients are on dual blockade, where they get chemotherapy, trastuzumab, and something called pertuzumab. Following surgery, they'll get something called TDXD or TDM1, which is an antibody drug conjugate. And that is also moving into the preoperative setting within the next couple of months. So this is just as taking breast cancer as an example. So I know this, I've said a lot of things which probably is not, you would think, why is this relevant to us? But I want to bring you to the breast cancer scenario where you see a patient with breast cancer, right? So they would probably have gone through these drugs, most likely, in any center in India or elsewhere. So one drug I want to start off with is something called anthracycline, which I think ma'am had already mentioned in the previous talk. So this is a red drug. Most of our patients, if you ask them, like if you don't know what drug the patient got, if you ask them, did you get the red medicine? Most breast cancer patients will say they got the red medicine. So this is very, very starkly, even in the IV bottle, you will see it as a red medicine. So what anthracyclines like doxorubicin and epirubicin cause is that they cause structural myocardial dysfunction and myocardial death. So it's a continuum. So as the dose increases, they cause myocardial dysfunction. And some patients, like around approximately 10% of patients will have subclinical cardiac dysfunction, but around 3 to 4% may have clinical cardiac dysfunction, and some of them may have echo showing more than 10% drop in LVEF. So why is this relevant to you? As I said earlier, this is the dose depends, the toxicity depends on the dose. And they can have either symptomatic heart failure, which obviously all of us will pick up in the pre-anesthetic clinic, but many patients have subclinical cardiotoxicity, which is not picked up. And if sometimes, you know, when we send patients in a high volume center, when we send patients, there may not be actually good evaluation done pre-op. So then it becomes, the responsibility is unfortunately passed on to you that, you know, this patient, have they had an echo in the recent last 3 months, or have they had an ECG? Have they had a clinical assessment? So that part can be done in the pre-anesthetic clinic so that you can guide the patient safely. Many times this gets missed out, although we try our best with protocols to kind of ensure that patients who are going for surgery have but sometimes it gets missed out. So how do we assess patients? So mainly in our center, we do echo and cardiac biomarkers like troponins if we suspect subclinical heart failure, and NT-proBNP, but cardiac MRI as well as nuclear medicine scans are available, but generally not clinically used. The assessments which are done, we do assessments every 3 months or every alternate cycle. We do assessment including ECG and echo. But then what happens is patient may finish chemotherapy, we are all happy, we send the patient for surgery. So the surgeons have given them a date few weeks or months later, and hopefully within a few weeks, and then the patient comes to you. By that time maybe they would have developed heart failure, and it may be subtle and it may be subclinical. So how do we pick that up and make sure that, you know, these patients are optimized before we take them for surgery? So one thing we can do is actually see whether patient has had high-risk features like previous exposure to cardiotoxic therapy, cardiovascular risk features, age more than 80, patients who have had a previous event, or patients who have LVEF less than 50% at baseline itself. So questions, I feel, these are all, I mean, there are no definite society guidelines except maybe the American Society of Breast Surgeons. But when we develop guidelines for ourselves, what we feel you should ask in the pre-anesthetic clinic is that, what was the drug given? Was it doxorubicin, epirubicin? Because doxorubicin has more cardiotoxicity at the same dose as compared to epirubicin. What is the cumulative dose? What was the date of the last cycle? Whether they have had an assessment after the last chemotherapy, whether they've had any radiation to the chest, and whether any concurrent anti-HER2 therapy like trastuzumab was given, which will again increase the cardiotoxicity. Clinically, what can you ask? So whether the patient has exertional dyspnea, whether they have reduced exercise tolerance, any palpitations, prior heart failure, when was the last baseline and recent echocardiogram, was there any drop in LVEF? The implications of this within the intra period is that if a patient has had significant anthracycline, I think we should assume that they have a reduced cardiac reserve. And then I need not teach you how you manage a patient with reduced cardiac reserve. So you can take precautions and follow your guidelines for managing patients with a reduced cardiac reserve. So these patients may not tolerate hypotension well. These patients may not tolerate anemia, blood loss well. And when you're giving induction and when you're giving intra fluids, you will know how to handle these patients, and you will be more careful as to, these patients may have a cardiac problem. So this is one drug. Anthracycline is one drug. The second drug is something called taxane, which is either paclitaxel or docetaxel. Why they matter is because they cause neuropathy. So these are microtubule stabilizers. They don't allow the microtubule to depolymerize. And what happens is within the neuron, when the microtubules are not allowed to depolymerize, the neuronal transport, the axonal transport is actually blocked. So then the nutrients are not reaching the distal part of the neuron, and then it causes degeneration of the neuron from the distal end. So how these patients manifest that they have peripheral neuropathy, they complain of numbness, tingling in the feet. Sometimes if there's large fiber involvement, they have gait instability, and many of them complain of fine motor difficulty. They're not able to button their shirt or wear their clothes. But I think the most important thing, if you see these symptoms in patients who have got taxane, what you should be worried about is autonomic instability. So that is something we don't assess. We don't, check whether the patient has postural hypertension routinely unless they complain of dizziness or something. But intraoperatively, what happens is if they have autonomic neuropathy, it will land up, patients will have difficulty, lability in the blood pressure, autonomic dysfunction intraop. I need not teach you. You will know what are the problems and implications of having severe autonomic neuropathy. And this is also a problem in patients who have pre-existing diabetes. The third drug which we give in breast cancer is trastuzumab. And not only trastuzumab, we have multiple molecules now, something called pertuzumab. There is another class of drugs called antibody-drug conjugates, where this monoclonal antibody, we attach, not we, the scientists who produced it, attach chemotherapy molecules to the antibody itself. So that these molecules, the antibody goes and binds only to those cancer cells and delivers the chemotherapy directly into the cancer cell. So these are drugs which are, nothing I'm speaking is now experimental. These are all routinely done in the clinic. We are giving to patients. So you will be seeing these patients in the OT as well. So the problem with trastuzumab is that it has another type of cardiotoxicity which is not dose dependent. It does not directly cause myocardial damage, but it causes a decline in EF. So the timing of surgery. So when you give anthracycline and taxane, which are chemotherapy agents, generally we just wait for 3 to 4 weeks for the marrow recovery and for anemia and the thrombocytopenia to recover, and then we can go ahead with surgery. For trastuzumab, there's no such problem. On trastuzumab, even if the patient got trastuzumab 2 days ago, you can operate today. The exception is that if they have cardiac dysfunction and known cardiac dysfunction, you have assessed and said there's cardiac dysfunction, they need optimization before that. The good things are no marrow suppression, no infection risk, no bleeding risk, or no delayed wound healing. So these are the 3 drugs. If I want to leave you with 3 drugs, anthracycline, taxane, and trastuzumab, because breast cancer is one of the most commonest cancers in the world as well as in India. But these are the drugs which can cause heart problems. So you have anthracycline alkylating agents, taxanes, Vinca alkaloids, the other monoclonal antibodies which I'll come to later. Tyrosine kinase inhibitors also I'll come to later. So there is a host of drugs, and there is this table I've taken not from our textbook but from an oncoanesthesia textbook by Springer Nature. This is an excellent table from your textbook which you can go back and read. The second cancer, which is a prototype which I feel which neoadjuvant therapy is the standard of care, is urinary bladder cancer. So these patients, the issue with these patients is bladder cancer occurs in around 80 years of age, right? The median age itself is around 70 to 80 years. So these patients already have a lot of other comorbidities, and we are giving them very strong chemotherapy. We are giving them 4 drugs. We are giving them a chemo regimen called DDMVAC. Now, in the last 1 or 2 years, there's something called enfortumab vedotin with immunotherapy, with pembrolizumab, which is again going to come in the next few years. But this is basically the treatment of bladder cancer. We give them very intense chemotherapy with taxane, with platinum. And these platinum agents, what they do, like the previous speaker ma'am had said, cisplatin is very nephrotoxic, and it can cause a proximal tubular dysfunction, and it can cause electrolyte wasting. Oxaliplatin generally causes peripheral neuropathy. Carboplatin mainly causes myelosuppression. So the platinum drugs, whenever you see a patient who has received platinum drugs pre-op, the renal function should be checked, GFR should be calculated, hypomagnesemia is a problem. So electrolytes, generally what happens is, like I said, when out of sight, out of mind. Patient finishes chemotherapy, after that nobody sees the patient till they come to you in the pre-anesthetic clinic. So unfortunately, that is what happens in most real situations. So the electrolytes are not checked for probably weeks. So this baseline, the dyslipidemia, the tubular dysfunction actually proceeds without anybody monitoring. Finally, the patient ends up in the theater, and then you do an ABG and you realize everything is haywire. So hypomagnesemia, hypokalemia, hypocalcemia, and hyponatremia. So this, I don't need to tell you that in patients who have bladder issues, hyponatremia, intraop is a problem. Intraoperatively, you need to avoid hypotension, avoid further nephrotoxic drugs, and especially aminoglycoside antibiotics can, if possible, needs to be avoided, and IV contrast during procedures. This I've already mentioned. The other cancer where total neoadjuvant therapy is colorectal cancer, where you have a long course of chemo and radiation. And then these patients come with, a lot of toxicity, a lot of, issues where if they, when you have radiation, you have issues to the bladder, you have problems with cisplatin and oxaliplatin, which is used in this setting for the kidney. And these patients come with a lot of, pre-existing morbidities as well. So one good thing, or one really revolutionary thing which has happened in colorectal cancer is that we have discovered something called MSI high colorectal cancer, where these patients respond extremely well to immunotherapy. So this graph is called Chalabi plot, after the doctor who, the madam who has actually presented this. She got a standing ovation in one of the major meetings in the world in oncology. And this is a waterfall plot. Normally it doesn't look like this. This almost looks like a lake. So this is basically the response of patients after the immunotherapy in MSI high colorectal cancer. So much so that most of these patients actually don't need surgery. They go into a complete remission. So just like leukemia, you give chemotherapy, it's cured. You don't do surgery and resect it out. In the same way, MSI high colorectal cancer, most likely within the next few years, is going to become a non-operative disease. But still there will be patients with MSI high colorectal cancer who need surgery, and those patients will come to you for surgery. The other cancers are like ovarian cancer, where we give carboplatin, which is a platinum and taxane, and bevacizumab, which is a monoclonal antibody against VEGF. The last cancer which I would like to stress upon is testicular cancer. So this is the man who cured testicular cancer. Testicular cancer was a death sentence earlier. He discovered something called the BEP regimen, which is bleomycin, etoposide, and cisplatin. And giving very intense chemotherapy with this cures testicular cancer, even in, like, so much so that we don't have stage 4. In testicular cancer, there is no stage 4. It's only up to stage 3. Even if it's metastatic. Do anybody, if you know any famous personalities who got cured of testicular cancer? Any cricketers? So he is actually treated by this doctor, and basically what happened is a disease which is killing thousands and thousands of young men. This is the most common cancer in young men. And what happened is he technically cured the cancer. I had the pleasure of meeting him in one meeting. So this drug, which is used in testicular cancer, bleomycin, which I think the previous speaker ma'am had already mentioned, the problem with bleomycin, when we enter oncology, this is like the first thing we are told. If a patient with bleomycin toxicity comes to the casualty with hypoxia, first thing what would we do? Put the patient on oxygen, put them in the ward and be happy. After a few days, patient will go into ARDS, worsen and die. So this is the first thing we are told. In a patient with bleomycin pulmonary fibrosis, we are not supposed to give them high FiO2 oxygen because it can actually rapidly worsen the oxidative damage. So bleomycin causes free radical formation, damage to the pulmonary alveolar epithelium, and it causes fibrosis. But the problem is the moment you give high FiO2, these problems worsen, compound, and the patient goes into intractable fibrosis and death. So what can we do intraoperatively? So pre-oxygenation 100% for 3 minutes and then reduce the FiO2 to maybe 30%. This is what is recommended by most societies and guidelines. You will know better than me, but this is what is followed in most theatres. So the pre-oxygenation 100% should not be prolonged for a long time, but we can use 100% FiO2 for pre-oxygenation. The more important thing is to identify patients who already have this. Like I said, we give the 4 cycles of BP, we're very happy, tumor has responded, now send the patient for resection of the remaining tumor. But the problem is this patient may have fibrosis underlying. Unless somebody evaluates the patient before the surgery, we will not know. So PFT testing, DLCO, especially in mediastinal germ cell tumors, if there is a suspicion, we have to do an HRCT. So we have a very low threshold now. Patient who has a dry cough, patient has a persistent cough, some mild breathing difficulty, we get an HRCT done. We don't even go through the standard algorithm, we just get an HRCT done because we have had issues in the past with patients who have severe bleomycin toxicity. So, this we have already covered. These are the other drugs which can cause, this is again the table taken from your textbook. These are the drugs which can cause pulmonary toxicity. Coming to the last drug, which is immunotherapy. So all of you would have heard of immunotherapy. Even every Tom, Dick and Harry gives immunotherapy. Ayurveda physicians give immunotherapy. Homeopathy physicians have immune boosting medicines. But that's not what I'm talking about. Okay, this is actual immunotherapy. I'm sorry if anybody has relatives in Ayurveda or homeopathy, but this is basically a Nobel Prize winning work by these 2 physicians, one in Japan and one in the US. So what they found was cancer cells evade immune suppression. All of us sitting here actually have cancer cells developing in our body every day, but our immune system clears it very well. But the problem happens is when these cancer cells express some immune checkpoints, and these immune checkpoints allow the cancer cell to shut down the activation of the T cell which comes to recognize it. So they found out which is the exact molecule which causes this, and then they designed an antibody to go and sit there to block this. So the moment this was blocked, initially it was done in melanoma, rats with melanoma everywhere in the body. He gave one of these drugs called ipilimumab, and what they found was the tumor melts away. So it's actually therapy, anti-cancer therapy, not just, we are giving something for immune boosting, like Chyawanprash or something like that. It's not like that. So many people think that, many of our patients think that, our doctor is immune is just, you're boosting it, I don't want boosting. So I am taking Chyawanprash. So this is the drug. This is one of the first drugs. It's called pembrolizumab. So the drug is actually, it's revolutionary in breast cancer, in triple negative breast cancer. So we give, most of our patients are on this drug or other immunotherapy preoperatively. And this drug has actually improved PAT-CR rates. It has improved survival in triple negative breast cancer, which is a very bad disease. But the problem with immunotherapy is it has got IRAEs, which are immune-related adverse effects. So it can affect any system in the body. And this is a list of side effects it has. It does not have side effects like chemotherapy, vomiting, diarrhea, hair loss. But around 10% of patients can have these, and around 3 to 5% can have severe side effects. So the mechanism of action, I'm not going into detail because of lack of time. So this is a patient with a normal colon, but after immunotherapy, you can see that they have severe colitis. This is severe pneumonitis. This is the figure E is actually encephalitis. So the F is actually sarcoidosis. The patient has worsening sarcoidosis on immunotherapy. G is just purpura skin rash, and C is actually vitiligo. So we have seen the spectrum of these. It's not that these complications are rare. We had a patient who got just 1 dose of atezolizumab, which is just a single immunotherapy for a small liver tumor. And then the patient came 3 weeks later, as a young lady, patient came 3 weeks later to casualty, psychosis, not able to understand what relatives are saying. Within 24 hours, she worsened, was in ICU, and she had we diagnosed her with a very bad brainstem encephalitis. And patient had, apart from that, patient had severe toxicity where the entire skin was, flaking off, very bad dermatitis because of immunotherapy. So it's not that these drugs do not have side effects. They do have side effects, but they are quite rare. So what should you take home from this is the endocrine, pulmonary, and cardiac side effects. So the most commonly missed side effects are hypothyroidism, hyperthyroidism, and just doing a TSH, FTC, and T4 before the surgical procedure will help. Morning cortisol 8 a.m. I don't need to tell you that if a patient has adrenal insufficiency, they may crash intraoperatively. So morning cortisol and electrolytes will save a lot of patients from, save a lot of anesthetists also from having to deal with our complications intraop. So pulmonary pneumonitis. So again, just like bleomycin, these patients can have an insidious progressive pneumonitis. So chest X-ray and CT if they have symptoms. Myocarditis is extremely rare, but it can be fatal. So patients who have symptoms, we assess them. Otherwise, routinely, we do not assess for myocarditis, but it's worthwhile getting a troponin done. Serial troponin elevation actually is a predictor for myocarditis. Intraoperatively, they can have hypotension because of adrenal crisis, pulmonary problems, cardiac instability, and if you feel that any of these patients have problems, I think you should have a low threshold for ICU care. I'm not going into the treatment of that or the gradation. We also have trials going on, multiple trials going on in our department where we give low-dose immunotherapy. That is now the paradigm in India. We give low-dose immunotherapy for these patients, and many of them will come for surgery to you for pre-anesthetic evaluation. And just the last few slides is about the new era of oncology, where we have, like I mentioned earlier, something called antibody-drug conjugates, where we have these monoclonal antibodies with chemo attached to them. They have their own side effects, like trastuzumab deruxtecan has an incidence of fatal ILD in about 3 to 4% of patients. So this drug is going to come, and you will all be seeing patients who will be exposed to this drug intraoperatively. Enfortumab vedotin is already being given in the preoperative setting in patients who cannot have cisplatin in bladder cancer. So that is also another drug. So because of lack of time, I'll just rush through these slides. So these are the tyrosine kinase inhibitors. These are just tablets, oral small molecules, which have been developed in the last 2 decades. I just want to bring your attention to these drugs called cabozantinib, sorafenib, lenvatinib, imatinib. So I'm sure you've heard of these drugs. So these are all tyrosine kinase inhibitors which target VEGF or RET, or sometimes MET. And these drugs actually cause problems in intraop as well as pre-anesthetic. They elevate blood pressure. So when you start taking the drug, within a few weeks, patients' blood pressure starts to rise, and we have to start them on amlodipine or other antihypertensives. But the problem is sometimes it gets missed out. Many centers, the patients may not be having routine evaluations. They just come, take the tablet, go for 3 months, and then come back. Our patients also take the tablet, go back, and then come back. So sometimes we may not even see the patient before they come to you for surgery. So that is, blood pressure monitoring is one thing. They can have cardiovascular problems like myocarditis, heart failure. And the most important problem I feel is wound healing. So there is another drug called bevacizumab, which is a monoclonal antibody. It's an injection against the VEGF. And if this is given, we need to stop it around our gynecological oncology and colorectal, they stop it around 6 to 8 weeks before surgery because it causes bad delayed wound healing. The lenvatinib, which is a tyrosine kinase oral tablet which we give for HCC and RCC, it should be withheld at least 1 week prior. Cabozantinib at least 3 weeks prior. These are actually not strict guidelines, but these are all based on the half-life of the drug and what the manufacturer suggests. The last drug is tamoxifen, which is all of you know tamoxifen, which is a selective estrogen receptor modulator, which is given routinely in breast cancer. It causes venous thromboembolism. So in patients who have venous risk of high-risk surgeries where thromboembolism risk is high, we need to stop tamoxifen at least 1 week before. So if you're taking home anything, this is just the last slide where it shows that cytotoxic chemotherapy, because of problems with neutropenia and thrombocytopenia, we need to stop it around 3 to 4 weeks prior to surgery. targeted therapies like TKIs, depending on the half-life, but at least 3 to 4 weeks, sometimes 6 to 8 weeks in case of bevacizumab, and as short as 1 week for lenvatinib. SERMs at least 1 week before, and immunotherapy, you can continue immunotherapy even on the day of surgery, but then we need to be aware of the complications and check. So if you're doing something, if you're doing evaluations specifically for patients, this can be the beginning of guidelines where you do an ECG echo, you can do a NT-proBNP, do PFTs for patients who have pulmonary complications, drugs causing pulmonary complications, HRCT if they're symptomatic, morning cortisol, TSH, T4 FTC, and a complete metabolic profile. But I would say that why the last question is, why are we doing all this for all patients? So I feel the most prepared physicians in the world are anesthetists. Right? You make sure that everything is perfect before you take the patient into this battlefield. But do we need to stick to routine care for cancer patients? I don't think so. We need separate guidelines because of all these things. I know it's a lot of information, and frankly, even we also need to learn, right? So we also need to have strict protocols before we send patients for surgery, which is non-existent in the country right now. So I feel that is the way forward, and thank you so much for giving me this opportunity to talk. Thank you.
Any questions from the audience?
Yes.
We had a very bad, after chemo, the IVC thrombosis, when they were about to clamp, it embolized and become a pulmonary embolism.
Yes.
Almost we lost the patient. Now, another case where partial immunotherapy was also given, where even when they are pressing, the tumor is not moving from that area because it is enframed with the IVC.
Yes.
So, do you come across or any suggestion from your side?
So first of all, I'd like to say nice to be back. So Sir was my teacher when I was in anesthesia, and all of you were my teachers. So the tumor thrombus in RCC, it's part of the disease itself. Sir. So mostly, I don't think that the therapy itself, unless it doesn't respond to therapy, it doesn't cause worsening of the thrombus itself, generally, sir. But with respect to the immunotherapy, that is a known complication that when we give, especially in lung cancer, a lot of our surgeons say that when we give immunotherapy, it causes a severe inflammation of the, especially lymph nodes and all. It's just stuck. Everything is kind of stuck there, as if we gave radiation therapy to that area. And then when we the surgeons try to dissect it out, they have a very tough time. So that is the reason why surgeons, stayed away from giving neoadjuvant immunotherapy for a long time. But later on, now we are realizing that even if the lymph nodes are stuck and the chance that lymph nodes have a pathological complete response, meaning the tumor is completely gone, is very high. So then even if we are not able to dissect out everything, whatever they dissect out, and if there's such an intense inflammatory response, it may be that they have a complete response. So even if you do a suboptimal dissection, finally, when they come out with all the lymph nodes are negative, even the tumor has complete response, that is why most likely patients have a good outcome at the end, sir. But this is a known complication, so that if, not in all diseases, but in lung cancer and like you're saying, sometimes in RCC also we do that. We encounter that, sir. But I think in RCC we don't give neoadjuvant, sir. In this, if it is resectable, we go ahead with resection and then give adjuvant immunotherapy. But in cases where it's unresectable at baseline, only there we do neoadjuvant immunotherapy with TKI. Sir.
As our urology surgeon, I don't know whether we had a multidisciplinary discussion after that case. We
Yes.
had a mortality. They said they are giving immunotherapy pre-op because this chance of embolization is more dangerous than getting that tumor inflammation. So
understood. Okay, sir. To have a cyto reduction. Yes, sir. We generally the only problem is that we don't have an RCT now showing that neoadjuvant immunotherapy in RCC improves survival. Those are ongoing, but many times, like I'm sure you.
Intraoperative embolization sometimes
there
very
is
dangerous even. Now
yes,
we are doing
yes.
those type of cases in the hybrid theatre.
Understood, sir.
Rather than because this patient we did in a normal urology theatre, then we have to move the patient to cath lab.
Yes, yes,
it took some time. But
understood,
now we are doing these type of cases.
Yes, sir. And I feel probably if neoadjuvant immunotherapy and if we have a cytoreduction of the tumor thrombus, it may help. It may help in that. Thank you. Thanks. Yes.
For lack of a cardiologist, I think I'll address it to you. Cardiotoxicity and all these drugs which you mentioned, echo, pre-op echo, what is the gold standard? Do you have something more? Or is it the right way to look at an echo EF of about 55 and say things are okay? Or do we have something better?
So in routine practice, you are right. So we generally do only echo, but we ask our cardiologists to do a GLS, which is a global longitudinal strain. That is one more parameter which we see, sir. And technically, if an MRI can be done, we can detect a lot of subclinical. But in the clinics, routinely in our practice, we generally do an echo and ECG. And if there is a drop of more than 10% to less than 50%, then we kind of get cardiology involved, sir. But even our cardiology team is also now working on adding, like if preoperatively patients are cancer patients are coming to them, they actually are starting a cardio-oncology clinic, where they can follow up more, do GLS for all the patients, report GLS and follow them up for subclinical heart failure. So that is something hopefully which will help in the future. So, but you are right, sir. Like we just doing an echo and in an inexperienced person's hands will not pick up most of the problems we are anticipating.
Yeah, so like one more practical problem in real life, like sometimes like you mentioned, like we do an echo and patient is waiting for the surgery. We did an echo, the EF is, everything is okay, and then you are given one more cycle of the chemotherapy because the patient is waiting. It happens many times, and in one or two times that, so the first thing is that should we repeat the echo after the, because there was some 4 cycles were given, echo was done, echo is normal, and given one more cycle because the patient wait list is more. So should we should we repeat an echo? Or we can just do some functional assessment test and can go ahead.
So I feel that in our guidelines it says no need to repeat echo, but I feel the guidelines should be different when the patient is going for surgery, especially if the patient has had one more cycle, because we've seen that curve. It's not like a linear curve. The toxicity actually is exponential. So if one more dose is given, it's likely that the curve goes up and patient has a toxicity. So we should probably repeat an echo before surgery if the patient has had a chemo in between the last.
So like in many times mostly we don't, because if the patient has not develop any cardiotoxicity in 6 cycle or 8 cycle, then one more cycle probably should not. But at one or two times, patient actually develop cardiotoxicity, and so I think so it is
better to be safe than sorry. So I feel, even though based on our guidelines we would not do it, but still I think doing it would be wiser. So that definitely I agree.
You suggest cardiac marker.
Some screening echo, at least we should also try to practice that. We give an idea before when you take these type of complex patients.
Yes, I agree, sir. I think Dr. Amit is working towards starting a.
I think as anesthetist,
Just one question, can I?
yeah, yes.
Now, you spoke about markers. Would you suggest doing markers, cardiac?
Yes, ma'am. Actually, in case of the myocarditis which I was talking about, serial troponin helps predict. So we also haven't started doing it clinically. We only do it in case of, clinically we are suspecting it and we want to confirm. But doing markers itself in isolation may not really help, ma'am.
So you mean to say if the ejection fraction is normal, but
Yes.
clinically patient is not good,
Yes.
that is when you are planning?
Generally, ma'am, in the clinic we are not routinely doing at all. But if we feel that the echo is not showing too much, and we are suspecting that patient definitely has a cardiac issue, we generally now we have started doing, ma'am. Exactly, ma'am, like you said.
I know, and some guidelines are also
Yes,
adding
yes.
that.
You said the drop by 10%.
Yes, yes.
Is that a EF or
EF,
global
EF.
EF?
EF,
Okay, so
yes.
then you send it for a
Yes,
You
yes.
said it.
So our definition, I mean, this is just a traditional definition, a drop in 10% to less than 50%. So if the patient, if it's from 60 to 51 or 61 to 51, generally it's not considered as concerning. But if it drops to below 50%, and it should be a 10% drop.
10%.
Or patient has clinical heart failure. That's it.
So, and the GLS is also, I mean, is it looked over serially or?
No, ma'am. Actually, the cardiologist reports it as a single value. Yes, at baseline they report it, and it's like I think minus 18, where you have a higher risk of having more risk of having cardiotoxicity. And then patients who are echoes normal, patient is sometimes we get patients who have clinical heart failure. Echo is absolutely normal, like preserved ejection fraction, no other problem. In them, the GLS kind of predicts that it is there.
Does it have an implication for you?
Yes,
for
yes,
the
yes,
dose?
yes, ma'am. Because we, if the patient has clinical heart failure, or if if clinical heart failure, we generally stop therapy. And sometimes in trastuzumab we restart it, but anthracycline we don't. But in case of patients who have, this is only on a trial basis. We had a trial where we gave combined anthracycline and trastuzumab. In those patients, we had MRI, GLS, and cardiac biomarkers. In those patients, when we saw a decline, we stopped therapy. So the only on clinical trial basis, not in practice.
Thank you.
Dr. Josh, regarding one scenario, the patient is having a good effort tolerance, but on the other hand, whether you will see likely to see a declining biomarkers to see is good enough to undergo anesthesia, but the patient if he having a good effort tolerance, but on the other hand, the parameters, the troponin and the NT-BNP is not coming down, or paradoxically it's going little up. In that case, whether we will be advising to hold the surgery for a while or to optimize before thing, or you will, since the effort tolerance is good, you can safely undergo the surgery like that.
I think, any patient who we are suspecting, like you said, so like NT-proBNP is going up, we generally want a cardiac clearance. And sometimes what cardio does is they preemptively start them on cardiac medications like ACE inhibitors, and then because there is also some protective effect of those drugs, so they start the patient on ACE inhibitors, give a clearance with, and they have this scoring system where they say that there is mild or moderate increase in risk, cardiovascular event risk intraoperatively, then we proceed with surgery. So if it's clinically patient is okay, generally we are okay to proceed.
Okay, one more question for the PG's point of view. At what neutrophil count the PGs need to be cautious in accepting the patient coming for surgery in a PSC?
Yes. So generally, I think the same guidelines for even when we give chemotherapy, ANC of 1500 is what we give as a hard cutoff. There are some guidelines which say ANC of at least 1000, but we follow ANC, absolute neutrophil count, of at least 1500. The WBC count is generally not so relevant, but we keep a cutoff of at least 4000. So I think that would be a good. And for platelets, you have your own cutoff, sir. But we generally say like 1 lakh for any major procedure, and at least 50,000 if it's a minor procedure.
We'll just stop discussions for now, because in the interest of time, we can carry this discussion towards
the guidelines. Yeah, sure.
Sure. So thank you, Dr. Josh, for your lovely presentation. You covered almost over every dilemma of all the anesthesiologists, I guess.
Thank you.
And thank you for telling us that the pre-op evaluation should be drug-related, and organ specific toxicities should be really addressed. So thank you so much.
Thank you, ma'am. Thank you, sir. Thank you.
Thank you, Dr. Josh, for sharing your unique insights and perspective on this topic, and concisely explaining on how a lot of it matters to us in our daily practice as anesthetists as well. Could I request Dr. Meghna to kindly give away the memento to Dr. Josh?